Imagine going into surgery to fix like a really terrifying structural problem in your body. I mean, an organ is literally falling out of place. And you wake up only to find that the very fix the surgeon used has basically rewired your nervous system.
Right. It's a devastating paradox, really.
Yeah, and imagine that fix triggering this agonizing, just paralyzing pain during intimacy. That is the reality for countless women who undergo procedures for pelvic organ prolapse.
You go in wanting to reclaim your quality of life, and you solve the immediate mechanical failure, sure, but you inadvertently create this highly complex, chronic, functional nightmare.
Which is exactly what we are unpacking today. Welcome to today's deep dive. We're going through a whole stack of clinical guidelines, surgical reviews, and anatomical studies regarding pelvic organ prolapse surgeries.
Specifically, we're looking at things like sacrocolpopexy and vaginal vault suspensions.
Right. And our mission for you, the listener, is to zero in on a very specific, frequently misunderstood consequence of these procedures. We are looking at how structurally anchoring the top of the vaginal canal fundamentally alters its natural biomechanics.
And crucially, how that alteration triggers debilitating pain during sexual thrusting, which clinicians call dyspareunia.
Okay, let's unpack this, because to understand how the surgery changes things for the worse, we first have to establish the baseline, right? Like how the body is actually supposed to work naturally.
Exactly. I mean, for decades, the surgical approach to pelvic organ prolapse was based on static engineering. It was like, if a bridge is collapsing, you just hoist it back up and bolt it securely to the bedrock.
Right, you want structural integrity.
Exactly.
Yeah.
So if the vaginal vault is prolapsing after a hysterectomy, the old logic was just, well, anchor it back to a strong ligament or a bone.
But the female pelvic floor isn't a bridge. I mean,
Right.
It is a highly dynamic, elastic biological system.
Right.
And when you apply rigid engineering to a system that relies entirely on movement, you set off a whole cascade of unintended, painful consequences.
Which brings us back to that baseline. We have to look at the mechanics of a natural, unaltered pelvic floor.
Yeah, and if you look at the foundational observations of Masters and Johnson regarding the physiology of sexual response, the numbers in these sources are just wild.
They really are. The vaginal canal is completely misunderstood by a lot of people. It is anything but a static, fixed tube.
Right. During sexual arousal, it undergoes this massive, active anatomical shift.
What's fascinating here is that the upper end of the vagina naturally lengthens by 3 to 4 centimeters during arousal.
Wow.
Yeah, and at the same time, it widens to an overall width of 6 centimeters or more. But what's really crucial here is the why behind that movement.
Right, because it's not just random stretching for no reason.
Exactly. The body is performing a highly coordinated evasion maneuver. In a typical anatomy with an anteverted uterus, meaning, a uterus that tilts slightly forward over the bladder, that entire structure actually elevates upward.
It pulls up into the false pelvis, right? That broader upper bowl of the hip bones.
Yes, rather than staying down in the narrow canal below.
So it is actively moving vulnerable parts out of the line of fire. Like take the posterior cul-de-sac, for example, that delicate pocket of space right behind the uterus.
Right, a highly sensitive area.
Yeah, and if someone has conditions like endometriosis in that pocket, you absolutely do not want that tissue getting repeatedly struck by a thrusting penis.
Exactly. The body instinctively knows this, so it actively creates space to protect itself.
And that biological adaptation is just incredibly precise.
It is. I mean, if a woman has a retroverted uterus, so one that naturally tilts backward toward the spine, this crucial expansion and lengthening actually happens more interiorly.
Oh, wait, really?
Yeah, the tissue between the bladder and the uterus expands to accommodate the specific angle of entry. The anatomy dynamically shifts its axis to avoid a collision.
I mean, think of it almost like a silicone collapsible travel cup, or a highly specialized shock absorber that dynamically expands to create space.
That's a perfect way to visualize it.
Because the canal is designed by nature to be highly elastic and mobile. It doesn't just sit there. It elongates and shifts to absorb the physical force of thrusting.
It is entirely dependent on flexibility. If you lose that 3 to 4 centimeters of expansion, you're losing over 1.5 inches of vital shock absorption.
And that flexibility is the only thing standing between normal sexual function and severe tissue damage. The tissue must yield.
Right. If it doesn't yield, the mechanical friction and impact of intercourse will cause acute trauma.
So this brings us to the surgical shift. Knowing that the canal requires elasticity and movement to prevent pain, what happens when a surgeon goes in and permanently ties that exact tissue to a bone?
Well, that is the exact collision course these surgeries create. When a patient has a vaginal vault prolapse, where the top of the vagina loses its support and drops down,
Yeah.
surgeons need to suspend it.
Right.
And the gold standard for advanced prolapse is often an abdominal sacrocolpopexy.
Okay, let's break down exactly what that entails structurally for the listener.
So in a sacrocolpopexy, the surgeon takes a strip of synthetic mesh. They attach one end of this mesh to the vaginal vault, which is the very top of the canal.
Okay.
Then they take the other end and attach it to the anterior longitudinal ligament of the sacrum.
That's a thick, heavy-duty band of tissue running right down the front of the lower spine, right?
Exactly. So structurally, the top of the vagina is tethered directly to the backbone.
And if they don't do the abdominal mesh approach, the sources say they might use a vaginal approach, like a sacrospinous ligament fixation.
Right.
This is where they stitch the top of the vagina directly to the strong sacrospinous ligaments deep in the pelvis.
Yeah, and here is where the functional mechanics really start to disintegrate. Let's look at sacrospinous fixation. Surgeons frequently perform this unilaterally.
Meaning just on one side.
Yes. Because of where the rectum is positioned, they will often take the top of the vagina and anchor it to the sacrospinous ligament on just the patient's right side.
Okay, wait, hold on. I'm getting stuck here.
Yeah.
How does anyone justify taking a tube that desperately needs to expand symmetrically and deliberately pulling it sideways? It seems like an inherent contradiction.
It really does.
I mean, doesn't unilaterally bolting it down to a ligament essentially guarantee it will be pulled out of shape during sex?
You are hitting on the exact fatal flaw of the procedure. Unilateral fixation naturally deviates the vaginal axis posteriorly and to the right.
Wow.
It pulls the entire pelvic floor off-center, creating this asymmetric tension on the anterior compartment. You are permanently trading functional elasticity for structural stability.
So you're pulling an elastic shock absorber permanently to the right and then expecting it to function normally when force is applied straight down the middle.
Exactly. And the mesh procedures introduce their own devastating mechanical flaws.
Right, because of how the body reacts to the mesh.
Yes, when you implant a synthetic mesh in a sacrocolpopexy, you trigger a foreign body response. The body recognizes this synthetic material and sends in fibroblast cells that build structural framework to lay down dense collagen around it.
So it builds scar tissue.
Yes, but as that scar tissue matures over months and years, it contracts. The physical pores of the mesh can shrink.
Oh, man.
Yeah, and this pulls the surrounding tissue tighter and tighter, physically narrowing and restricting the vaginal canal. It's not just a tether anymore, it's like a tightening net.
So we have a vaginal canal that is tethered to a spine, potentially deviated sideways off its natural axis, and steadily restricted by contracting mesh and scar tissue. So when sexual arousal occurs, that necessary 3 to 4 centimeter lengthening is physically impossible. The apex is bolted down. It's locked in a vault.
And that leads directly to the physical reality of dyspareunia for these patients. Because the surgical anchors prevent that natural expansion, the physical force of thrusting no longer meets elastic yielding tissue.
Right. It meets a rigid, unforgiving barrier.
Exactly. It's a high-velocity collision.
Doing the math on that is horrifying. I mean, if your body requires 4 centimeters of space to avoid striking sensitive organs, and the surgery eliminates that space, every single thrust is a direct impact against a tethered wall.
The forces of penetrative sex are now impacting a completely fixed point. The vaginal apex, that suture line at the very top of the canal after a hysterectomy, becomes the focal point for all of that kinetic energy.
And the clinical data shows exactly what happens next. The sources say this tethered apex becomes exquisitely sensitive.
Yeah, that's the clinical term for it.
And the part that really shocked me is that the patient doesn't even need to have a catastrophic surgical failure, like the mesh eroding through the vaginal wall, for this to happen.
No, not at all.
The pain can be so intensely focal, so specific to that anchor point, that a doctor can take a simple cotton-tip swab, lightly press it against one quadrant of that surgical apex, and instantly trigger the exact severe, blinding pain the patient feels during intercourse.
That cotton swab test is such a crucial diagnostic indicator. It proves that the pain is purely mechanical in origin. It is localized exactly to the site where the tissue is restricted.
Here's where it gets really interesting, though. A highly specific detail from the sources. The collision isn't just felt by the patient.
Right.
There is a complication with the sacrospinous fixation that really illustrates how rigid these repairs are. Sometimes the surgeons use rigid, non-absorbable monofilament sutures to hold the tissue to that ligament.
Right, because the ligament is under a lot of tension, you need a heavy-duty anchor.
We are talking about thick, permanent structural threads. But think about the patients getting these surgeries. Many are postmenopausal.
Oh, yeah.
Because of lower estrogen levels, the vaginal mucosa, the skin lining the canal, it thins out.
Mm.
So those thick, rigid sutures don't always stay buried deep in the tissue.
Oh, yeah.
There are documented cases where the partner actually complains about feeling these non-absorbable sutures during intercourse.
Yeah.
The structural fix literally turns into an exposed wire that causes physical pain for both people involved.
It is a profound disruption of intimacy. But if we connect this to the bigger picture, to fully grasp the severity of this pain, we have to look past the mechanical bruising and look at the neurology.
Right.
We need to understand how this repeated collision physically rewires the nervous system in the pelvis.
This is where we get into neuroplasticity, right?
Yes.
The nervous system actually adapting to the trauma.
Precisely. The pelvic region is densely wired with what are known as C nerve fibers. In a healthy, elastic pelvis, these fibers are mostly silent. They have a high threshold for pain. They don't fire off warning signals during normal sexual function because the tissue yields.
But when you introduce this repeated mechanical trauma, thrusting against a rigid, surgically tethered wall, you are constantly damaging the tissue.
And that damage releases a biochemical inflammatory soup. Prostaglandins, cytokines, all these inflammatory markers flood the localized tissue at the surgical apex.
Oh, wow.
And this chemical bath fundamentally alters those normally silent C fibers. It lowers their firing threshold.
Meaning it takes way less physical pressure to trigger a pain signal.
Exactly. It's a process called peripheral sensitization. The body perceives the restricted thrusting as a repeated severe injury.
So trying to warn you.
Yes. As a sequel to these repeated traumas, the nervous system ramps up its defenses. Those C fibers become hyperactivated. They start firing intense pain signals at the slightest provocation.
This is how a mechanical surgical fix transitions into an autonomous chronic pain generator. The nerves literally learn to be in pain.
They really do.
So the surgery effectively stops the prolapse, but the mechanical collision rewires the localized nerves to constantly scream, danger.
Exactly.
And if it stopped there, it would be bad enough. But the nightmare doesn't stay at the surgical site. This sharp, localized nerve pain triggers a massive secondary chain reaction across the entire pelvic floor.
Right, the domino effect.
Right.
Pain never exists in a vacuum.
Yeah.
The brain and the surrounding musculature react to this nerve firing and the altered biomechanics.
The clinical term for this, from the outline, is levator spasm, or pelvic floor tension myalgia.
Right. The pelvic floor is essentially a complex muscular bowl that holds everything up. The main muscle group is the levator ani.
Okay.
When a patient experiences that blinding, acute pain of hitting the rigid surgical anchor during sex, those levator muscles react defensively. They go into a state of constant protective contraction. They spasm to guard the injured apex.
You know, it makes me think of favoring a bad knee. If you injure your right knee, you start walking with a limp to keep the weight off it. You are protecting the joint. But because your gait is entirely thrown off, you are forcing other muscles to compensate. 2 weeks later, you throw out your lower back.
Yeah.
The rigid anchor at the top of the vagina throws off the entire pelvic support network.
That knee analogy is spot on.
Yeah.
And to take it a step further, imagine you can never sit down and take the pressure off that bad knee.
Oh, that sounds awful.
The muscles around this surgically altered tissue are essentially locked in a permanent internal limp. They never get to rest. That is why the pain spreads from a tiny focal point at the top of the vagina to encompass the entire muscular floor of the pelvis.
The clinical case studies on this are harrowing. There's one specific case of a 55-year-old woman who had a history of these exact pelvic surgeries, including synthetic mesh placement and sling surgeries to hoist the tissue.
Right, and the resulting cascade in her body was total functional breakdown. She developed severe insertional pain.
Yeah.
But when the clinicians examined her, they didn't just find pain at the mesh site. They found severe pelvic floor hypertonus.
Which means her pelvic floor muscles were entirely locked up, basically paralyzed by their own tension.
Exactly. The levator ani muscles were in moderate constant spasm. The localized nerve trauma from the mesh had radiated outward, causing the entire muscular bowl to clamp shut.
And the practical reality of living with that level of levator spasm is unbelievable. I mean, it goes way beyond just pain during sex. A detail that really struck me. These spasms can become so severe that a woman cannot comfortably sit straight up in a chair.
Because the posture of sitting puts direct mechanical pressure on those spasming levator muscles.
Right. So to just exist in a chair, she's forced to constantly lean far to one side or slide completely forward in the seat, so all her body weight is resting awkwardly on her tailbone, just to tolerate being seated.
It's tragic.
The surgery she got to improve her quality of life has made sitting at a dinner table agonizing.
This raises an important question, doesn't it?
Hmm.
Are we too obsessively focused on the visible structural anatomy of a prolapse, like the sheer mechanics of an organ falling, while completely ignoring the functional muscular elasticity required for a normal human life?
It certainly seems like we're treating the patient like a broken car rather than a living organism.
Exactly.
When you combine the nerve entrapment and the surgical scar tissue with this high-tone pelvic floor dysfunction, penetrative sex becomes physically impossible. And not just because the surgical site hurts, but because the entire canal is in a state of defensive spasm. The body is literally locking the door to prevent further mechanical injury.
And treating the secondary cascade is incredibly difficult because you can't just treat the muscle spasm.
Right.
You can prescribe intensive pelvic floor physical therapy or even off-label muscle relaxants like vaginal diazepam suppositories. But the muscle spasms often will not fully resolve because the underlying structural trigger, that rigid tether, is still there, constantly irritating the nerves.
So what does this all mean? Synthesizing everything we've looked at today, the primary takeaway is this profound lesson in biomechanics.
Absolutely.
Anchoring the vaginal vault to bones or ligaments is undeniably a highly effective way to stop an organ from prolapsing out of the body. It solves the static architectural problem.
But the human body isn't static. These surgeries fundamentally destroy the dynamic, expanding nature of the vaginal canal.
Right.
They turn the natural elastic forces of sexual arousal and thrusting forces that require 3 to 4 centimeters of give into a traumatic collision against a rigid, unforgiving wall.
And we now know that collision doesn't just cause momentary friction. It unleashes a biochemical response that wakes up silent C fibers, turning them into chronic, hypersensitive pain alarms.
Which in turn triggers the surrounding levator muscles to lock down in a defensive, exhausting spasm.
The surgical fix secures the structure but shatters the mechanics.
It demands a total paradigm shift in how the medical community approaches pelvic floor reconstruction. We have to move away from purely structural engineering and prioritize functional preservation. You cannot sacrifice the movement for the anchor.
Which brings us to a final provocative thought to leave you, the listener, with today. Something to mull over. We've talked endlessly about how surgeons kind of guess at the right amount of tension, often pulling things unilaterally and just hoping it works out. But the sources briefly mention a glimpse of a different future.
Right. Researchers are beginning to utilize a technology called vaginal tactile imaging, or VTI.
VTI?
Yeah, it's fascinating. It's essentially an advanced biomechanical mapping tool used in vivo. It allows clinicians to actually quantify and measure the exact mechanical properties of a woman's pelvic tissue.
Right. It maps out how elastic, how firm, and how functional the individual tissues are, rather than just looking at a static anatomical picture.
Yes.
So, building on this, taking it to its logical conclusion, could we be heading toward a future where doctors use technologies like VTI to create a personalized 3D digital twin of a woman's pelvis?
The implications of that would be revolutionary. I mean, instead of a one-size-fits-all mesh tether, you have a dynamic digital model of the patient's specific elasticity.
Exactly. Imagine a world where before a surgeon ever makes a single incision, they run virtual biomechanical intercourse stress tests on this digital twin.
Oh, wow.
Right. They could observe exactly how placing a specific piece of mesh or anchoring a suture to a ligament will alter the physics of thrusting and expansion for that individual patient.
You could predict the exact point of collision before the surgery ever happens. A surgeon could mathematically tailor the surgical tension to ensure the canal retains its necessary 3 to 4 centimeters of elasticity rather than just bolting it down blindly to the spine.
It would be the ultimate evolution from static medieval bridge engineering to dynamic, personalized biomechanics. And maybe, just maybe, that level of functional mapping is how we finally stop trading structural stability for functional agony. It is definitely something for all of us to explore and think about.